Gary has a question? Oh, my God.
Hey, great presentation by Ative and Omar. Yeah.
A little cheat sheet.
No, and it's kind of funny. I think it's about 2 years ago, or maybe more than 2 years, me and Omar got together and we were talking about the same project in Washington, D.C. at Ward 8, and we were trying to strategize and saying how we're going to be a part of this project. And this is the idea. He is an African-American, a black person. I'm the same. I'm heading healthcare and he's heading healthcare for his company, and we're saying they're going to build a project in an underserved community. Correct. It's like a ghetto that don't have good access to healthcare. That's something that it really energizes us. We're like, listen, it's for our people. We're going to figure out how we're going to get a chance to lead this type of project. We formulated a plan, and I remember the groundbreaking. Omar and I met on site, and it was just a joyous time for both of us because both our team are leading a project that's so important, for people in Washington, D.C., where we, reside. And, I can't say enough in terms of our excitement to do the same thing, to bring it back to Jamaica. And that's the reason why I think being a part of this conference is important to us, because we have to continue the conversation. We have people in the diaspora that can help and can really move the needle. And thanks for your effort, Omar, in terms of what you're doing at Ative. It's the same thing. I just want to say that and qualify, just to say, we're going to continue to push on. I don't have a question. I just have to congratulate your team.
I appreciate that. I got to survive that one.
Thank you, Omar. Great presentation to both of you, Ennis as well. Okay, so you recognize all of the phase of building a health facility, from the design to the construction to commissioning and operation. One of the downfalls of countries in the Caribbean with regards to healthcare facilities is the lack of maintenance planning, programming and maintenance planning.
Yep.
All right. What general guide would you give ministries of health here in the Caribbean countries in terms of what should be budgeted? What percentage, based on the construction costs, I don't know how you do that, should be budgeted as part of ongoing recurrent maintenance costs? Right, that's a ballpark, and any other little pearls you can give with regards to maintenance, because it's a sore point to see where you can have a great facility that starts, and then a few years down the line, and I can give a particular example, Cornwall Regional. When it started, it was a magnificent facility, right? Way beyond this time, but now over the years, through neglect, lack of maintenance, lack of ongoing refurbishment, become dilapidated. That's right. I will. You can hold that thought. So, yes, as a physician, I'm a doctor and a physician, and I spend. I'll tell you, yes, you're correct. Within 1 minute, you probably know the diagnosis. You probably know the diagnosis. But the other few minutes is spent around trying to determine the cause, and that comes with history taking. And you want to get to the root cause of the problem. And then the other few minutes that I take, a whole 15 minutes, is spent on educating the patient around preventative strategies and educate them about their disease, the problem, and how they can go and address the problem. And I think that's how most physicians should practice. In this day and age, I have 2 offices, and I make a point of I don't take anything in the room with me. I don't take a pen, I don't take a paper, I don't take a tablet, an iPhone, and I go, patient there, I'm here. I only have 2 skills, my hands, my ears, my eyes, and my mouth to talk and communicate, and my hands to examine. And by the time you finish, because what we find is that a lot of patients I know are accusing one of the downfalls of electronic health records and other tools in the computer a lot of patients are accusing doctors of saying, oh, I'm speaking to you, I'm in here Googling my diagnosis. I could have done that myself. And they always say that. So instead of you focusing on them and listening, you on your computer and typing in at the same time. And I mentioned in one of our sessions day before yesterday that some of the biggest challenges of electronic health records is that the stress that physicians have in having to write volumes of notes in the records afterwards, sometimes at home and long at nights going records. And thank God for some facilities have the opportunity to employ scribes where they can actually follow you around and type in for you, right? So that's just a comment on that side. Now, for you with regards to, I know this whole idea about unstructured health data and big data that is used within all of these AI models and used as part of blockchains and etc. Ethics around the collection and the selling of the structured data that comes from my personal record that I'm not advised about or the hospitals doesn't sell. I mean, what are your views around the ethics of that, of sourcing and selling unstructured data that can be used? Mine is useful because through all of the research that we have to do and to come with health solutions that is needed. Because what AI is also doing is the same thing about getting information and putting it back out to you, the consumer, but not giving the accolades to the source from which it came. Right. And the same thing goes with intellectual property, with copyright laws and everything else. So what are your views on those things that may challenge our health system?
Okay. All right. Let me quickly get out of the way by just talking a little bit about, operation and maintenance management for a hospital facility post-construction. Maintenance planning starts before construction, to be honest with you. It starts at the early stage of even planning to build a hospital. Part of, I'm involved in a lot of early stage talking, conversation with clients, especially when we're managing programs for, large programs for government agencies, and one of them can't really mention the name of the government client right now, but I was involved in this conversation Monday and Tuesday of this week. It's really, for example, if Jamaica is embarking up a healthcare program right now to build 4 or 6 new hospitals, and then upgrading 40 or 30 healthcare centers, one of the things you want is to have a trained staff to be able to manage those facilities after construction. So from a programmatic standpoint, what were some of the early conversations would you think about? You want to make sure you have similarity in equipment, because once you train and develop operations manual, you want to know that somebody in region A can also service region B, region C, because they're used to the same mechanical equipment, they're trained on it, the operations manual are universal across all hospitals, right? You try to have uniform systems in place. It helps also to bring down costs in terms of construction costs, because when you're buying these equipment from one manufacturer, you get bulk rates. So as opposed to you individually going out and securing contractor A for this project, contractor B for this project, contractor C, and each contractor has the responsibility of going out and buying a piece of equipment that can meet the specification per se that is written. And if those specifications are not written in a way where it gives propriety to one particular type of equipment, then the contractor has the right to go out and buy a piece of equipment that meets the spec and telling you, as a client, that this is what I'm going to install. But if you want a particular equipment in mind, the end users, which are typically the doctors and the nurses, say, no, I want GE products because GE is what we know how to read and use and understand. But the contractor said, no, I'm bringing in Siemens because Siemens also meets the requirement. And again, I'm not saying we should give priority to any one particular manufacturer, but planning, medical equipment planning as part of early construction, which ties back to maintenance costs later, is important in operation and maintenance. You can see how all the pieces come together. And that's why the planning piece is important, training is important, and then understanding the requirements because a new building not necessarily going to have the same maintenance need as an older building. So if the facilities are new, you have a longer period of time before certain major overhaul capital programs that needs to be done to keep those equipment and so forth running efficiently, or even the building features to be upgraded and so forth. So those are considerations, right? Early costs for maintenance versus mid-year, after 5 years, after 10 years, after 15 years. What is the design life for each particular, equipment that is installed? Those are early considerations. So I don't have a number in mind to say maintenance should be considered X amount of dollars as part of your operation cost for the year. Maybe Gary will have some of those references because he...
So I'm gonna help out Omar in this one. Typically for a 500,000 square feet hospital, Cornwall is about, well, in total, in aggregate, is about 390 square feet for the building, but there's other buildings surrounding. For a 500,000 square feet, the total operation cost is usually between 1.5 and about $3 million US. So that's up to $450 million Jamaican per year. And I'm hearing numbers, it's funny, I was just listening to the budget and hearing 300 million allocate to something and I'm like, that can't even take care of anything in the US, but it's what we have. It's a challenge. And if we were to segregate and look at HVAC and maintenance costs for that hospital, so that's, I'm talking total operational costs. We're looking about at least about 150 million of that is for facility maintenance. So that's a significant amount of money, which, to be honest, we don't spend and we don't understand, and that's something that we have to do. We have to do much better. The scale is tremendous, and it's a lot of money. And facility folks are paid a lot of money in the U.S. to do this stuff.
Yeah, I think we were actually talking about this at breakfast this morning. That you have a lot of assets in Jamaica. For example, hospitals. At Cornwall, the last check was about 15 billion that has already been spent. We could have built a brand new hospital for 12 or 10 billion. So when you have an asset that costs that much money, within the context of things, $150 million a year to maintain it and preserve it so that it has longevity is minuscule, and that's the kind of thought process that you have to put into being. Regarding the question that you asked about ethical considerations, that has always been a year-long adage. How safe is my data? What's going on? Who has access to it? And so on and so forth. And what a lot of people don't realize is that the data aggregators, you're giving authorization to them when you click accept at the bottom of that page. Normally they make it so fine that you can't read it, and it's 15 pages, and it's legalistic, and it's designed specifically because people will get frustrated and just scroll to the bottom and click accept. And what you're authorizing those persons to do is all manner of things. To use your data, to share it, to curate it, to use it in their marketing materials, you're giving them authorization. So you have to be a lot more careful where that is concerned. In our space, every single thing that we do, it requires authorization from the persons who are part of the program. Every single thing. And we operate under Sarbanes-Oxley. When we do projects in Europe, it's GDRP. And in Jamaica, the expectation is that we're going to operate at the same global standards and adhere to the DPO considerations whenever we're handling patient data. We do not include demographic data in any of our distribution, so no name, address, age, and so on. We may use gender depending on the type of research that we're doing, but the collection of this data is critical to being able to develop new therapeutics to treat different types of diseases as we go along. So it's not going to go away, it's just making sure that we're following the right standards so people are protected. Okay?
Thank you so much. I think you answered a part of my question because I wanted to know what were the indicators that NIH was pulling from the database.
Right.
But you mentioned that the biographics, the bio
right. They don't collect.
Go.
Yeah, no.
Right, because there's different culture, different places of the world. So
right.
is there like a core set of indicators that they're pulling
yes.
from the data
yes.
set? So
yes.
you answered that one. So I'll make two quick comments on basically your presentation, Omar. In budgeting for maintenance, I think the discussion didn't include the human resource for health. That's critical and important. And it's also training, because I think it's the core of medical expertise that would need to be built to help to facilitate some of that. And then my last comment was the accessibility. So I'm going to ask, I wonder if you can take a walk over here, Madame Patsy Edwards-Henry, past president for the Nurses Association. Come on over here. She was really, we were looking at that schematic diagram you built out with the tiers in terms of the secondary, the regional, and the community. And I think the health system was designed with geographical location in mind. I mean, we've expanded the population. Now we're at 2.7. Well, hopefully census will give us above 3 million. Yeah, but that has changed. Urban-rural migration, population shifts around the country, so you might have different needs now for different types of hospitals. But she was mentioning the where is she? Oh, here. The accessibility.
Hi, good evening, good afternoon. Yes, I heard you saying get into the hospitals and the time, but there are two things that you have to consider when you look at that. We have to look at the hospitals that we have in terms of the category, because our hospitals are categorized A, B, and C. Right. And even with a heart attack, the C hospitals are not equipped to manage a lot of these conditions. So we only have 2 A hospitals in the government system, plus the University Hospital of the West Indies, which is multidisciplinary. Most of the other hospitals are either specialized or scaled down. And so accessibility, while we do have the facilities, accessibility in terms of even transportation, because we don't have an ambulance service. So there are a whole lot of logistics that we have to look into when we look, talk about getting there in 20 minutes or less.
Correct.
Because you will be in and around Kingston and then based on sometimes the volatility of some of the communities, it's difficult to get transportation in and out to a facility where you're able to access the level of care required.
Correct.
So that was one of the things that was going through my head.
Sure.
I told Dennis to ask.
And it is certainly relevant because that's part of the consideration. So when I'm talking about building out a healthcare program to deliver on the level of service that you would expect to say, if the strategic objective is to make sure that every single person in Jamaica, if you suffer from a heart attack, can get to a primary care facility, a type A facility that can treat that condition, should be 20 minutes. Then what are some of the urban planning considerations are we putting in place? And it might not be via, the network of roads. It could be part of the service, but in some cases you might have to be picked up on a helicopter and taken to a particular, you might get to a type C facility or a district health care center or one of those healthcare centers that are level 2, and then picked up based on a system of transportation that are in place to support the transportation of patients and to get to a type A facility, because you might not be able to get there because there's not an ambulance service, or you might not be able to get there because of traffic or whatever other conditions transportation-wise that as inhibiting in getting to a facility to care for you.
I think, just to add to what Omar said, I think one of the critical considerations that we may have to put through, and I know we're talking about cardiac arrest as a underlining factor, but maybe it's not the best example, but because in a cardiac event, you literally become unconscious within 30 seconds or 30 seconds to a minute, in a sudden cardiac event. And then if CPR is not applied in the next 5 to 8 minutes, your prognosis for a good outcome decreases by almost 90%. So what would probably be a more effective short-term strategy, given the consideration around resources, is perhaps to strategically upgrade some of these community healthcare facilities and deploy defibrillators, which is a very good way of applying early forms of care, or you start to train people in CPR, which is also a very good form of early care that can send an electrical shock and restart the heart in that period of time while they're in transit to the hospital and so on. So there are other ways that we can take advantage of our current circumstance of a lack of resource, lack of proper ambulatory care, and still, have better outcomes by doing, these things that might not cost us as much money,
Yeah, I just wanted to make a comment also. As a strategic initiatives, and the government is doing that with certain surgeries and diagnostic and treatment also, is that you have a lot of private facilities as well that's available. To be honest, it's going to take a lot of time to really build these facilities to meet these requirements. But I think private-public partnership has to be an important part of the solution. And, what this takes is negotiation on the part of third-party payers, if it's insurance, and negotiating with these private hospitals and have some ways in which we can basically set some fees and cost structure that is affordable enough to attract some of these private hospitals. And that could be an interim solution. These are the stuff that that keeps me awake and that I think about how can this work, because it's truly something that we have to consider. Even building some more type A facility, how can we have some private-public partnership to make this occur? Canada is doing it with most of their healthcare system, P3s, and most of the South American countries are implementing P3s as a solution to meet these problems. And even in the US now, P3 is becoming prevalent. So this is something that we just have to think about. It's there's solutions there that's available, that's been used by other countries. And I think it's imperative for us to really just reach and just look and just utilize some of these that's available.
Any other questions? I know I'm standing in the way between happy hour and... All right, well, if there's no further questions, thank you guys. Thank you very much for our participation, and certainly look forward to continuing the conversation, and looking forward to seeing you at the next conference.